Right, if everybody could go on mute, please, because we're getting some feedback. Okay, so now we're going to move on to the performance report. James, would you like to kick off? And you're still muted, James.
It's impossible.
I did tell everybody to mute.
So I think a few things have been covered today, so I'll be a bit brief and assume people have read it. Just to add some understanding, the two key areas of surge that are drawing people from other areas to support is ITU and the medical surge rotors. This year around ITU, people come from across the trust, but heavily from theatres. So 104 theatre staff were redeployed to ITU in total. So that has had a huge impact on our ability to do elective work, in which we all but stopped. We only did urgent cases. We always do emergencies, but we did urgent and cancer. We kept that through. And the medical rotas meant that we stopped the vast majority of clinics for medicine. We would run virtual where we could, and we ran what we needed to in terms of urgency, but doctors were fully deployed to the wards on a 4-day off, 4-day on rota system through the whole of the second wave, as they were the first wave. So when you think about the urgent care position and the other positions in terms of constitutional standards, that's an important backdrop. We did have, throughout February and January, we had access to the Runnymede, so we used 2 wards in the Runnymede Hospital, which is joined to us here, and we converted our elective orthopaedic ward at Ashford to trauma, which goes back next weekend to its elective function. So that created a number of pressures, but we're through, now that we're in sort of out of that peak, we're trying to do people recovery. And when you could see starting to come back on this report, but that's February, March is busier, urgent care is getting busy. And at no point, as we backed out of our COVID missions, when you look at the COVID graphs coming down, it at no point meant our hospital was empty. If there was a graph of non-COVID, it just took its place. So as COVID came out of the organisation, non-COVID came in. So we were not at any stage during the let off of COVID in an empty hospital. The latent demand through urgent care and the green emergencies just took the COVID place straight away. So that has created a constant pressure on our urgent care system, which is now up to, it's pretty much up to pre-COVID activity, which is a bit of a worry because society is still mostly locked down. So we're working on issues around that, but from February you can see that there's a significant step change in our urgent care performance against the 4-hour standard, which put us around the top third of trusts in the country for February. In terms of length of stay on page 8, we have sort of considered that previously, but you can see that our length of stay throughout this period and throughout the last 12 months for over 7 days and over 21 days is significantly reduced, which does help flow through the organisation. It's a combination of a number of factors with support from provider partners and all the things that we've done during COVID to support patients being back to their place of residence. In terms of elective care, you can see in the papers, we made really good progress between the 2 waves in restoring some of our elective services, and that's dropped back down again as we, for the reasons I've just described, that important backdrop of the surge that we were supporting. Our waiting list has remained static. So since about October, November, so we're sat at around 26,000 patients on an RTT pathway. That isn't because that we've been able to raise up our elective services to meet that demand. Our ability, our capacity has come right down, but so have referrals. So our referrals into the organisation have been significantly reduced during the last wave. So that gives us a number of things to think about. One is the reason we've retained our waiting list isn't because we've stepped up our elective activities. We stepped them down significantly, and referrals came down as well. So that gives us something to think about. An implication there is demand in the community that hadn't been referred to us. We've been referring to that as latent demand, and whether that will come, there's different views on it, but that's the reason that we've stayed static, is that referral into the organisation. In terms of electives, we have to just mention Ashford. Ashford is an important part of our restoration. It was very important during the NHS plan, highlighted the importance of trying to split elective and non-elective sites where Trust had an opportunity to do that. And we were already on that pathway. In terms of COVID restoration, there are standards set out in terms of can you ensure green pathways, can you ensure green wards, and the gold standard is can you ensure green sites. So there are two key sort of national lenses there of which we are performing very well in terms of how we're configuring Ashford. And from the 19th of April, that will start to go full swing in terms of being our elective outpatient and diagnostic hub for the organisation. In terms of diagnostics, we were able to keep that activity up in the main during the second wave. So we were able to keep up our diagnostics, our imaging, and we had a recovery plan around endoscopy. And you can see that that is all making progress, and we're looking to have endoscopy compliant to DMO1 from during April. So that means that our trusted DMO position is, will be significantly improved, and we'll be looking at compliance relatively soon after that. So it's a huge step forward for us under a number of agendas, whether it's performance, quality, and that's really important to recognise that. And in terms of cancer, it's a fantastic effort in February that we've met all of the index measures for cancer performance, all of them. And those of you in the quality report said we looked at those patients that haven't been seen, and all of that's coming down as well. So it's a really good performance, a really good reflection of the teams, and a reflection of how behind the scenes we've been able to move things around and continue to provide that urgent element of our service to the patients that really needed it, as well as to the COVID services. Chair, I wasn't going to say much more on that this morning because we have sort of covered performance in a number of peripherally and tangentially in a number of other reports.
No, I think we'll just take questions, James. So, Marcin.
Thank you, Chairman. Thank you, James. I've of course commented on this several times so far. Something new propped up that I'd like some information on that I read in Aspire is that we're moving our Woking walk-in center to CSH, which means it won't be part of our statistics anymore, or is that an incorrect assumption?
Yeah, that's correct, Marcin. So we aren't moving anything anywhere. So it was provided by a community provider who had run it under a subcontract and are now going to run it under a different one. So we didn't have a lot of say in that, but it doesn't really matter potentially as long as the same cohort patients are seen in the same way. It's important that we have links around pathways so that we're not referring, patients aren't attending there and then attending here. So as long as those quality standards and stuff that we've got that sort of underpins all of that stays the same, then it shouldn't make a difference to us.
Let me take that as well, Marcin. So yes, both the walk-in centre at Ashford and the one in Woking were provided to our community colleagues under a subcontract. They've now taken that on directly. Obviously, the staff have TUPE'd or will TUPE as of 1st of April. And we anticipate a raising of standards rather than any lowering of standards. And of course, we can still incorporate the figures as agreed with NHSEI.
Okay, that's helpful. So there's no financial implications either. For some reason, I thought they were under our trust, but I'm obviously misunderstood. Thank you. Just my last question really is just a latest position, James. Yesterday, nationally, for the first time in several weeks, the number of patients in hospital with COVID went up rather than reduced. And I just wondered if you could tell us what our current position is.
Yeah, so we've got 12 patients in the organisation at the moment with confirmed COVID, and none in ITU. So, I mean, that figure hasn't moved really. We did get down to 10, but when we're at such low numbers, it's just sort of normal variation. But we are preparing for the next whatever comes our way. So this week alone, we've had 9 after-action reviews with all the key services in the organisation, including corporate services in the States, around just preparing for the next wave. So, if there is one. So whatever we need to prepare for, we need to just be fleet of foot and flexible and have finesse around what we've had the opportunity to learn. Through the first wave, we concentrated on COVID. Through the second wave, we did COVID and elective services. And I think there's a lot to learn from how we cope with future things. So we're preparing for that, and the board should take assurance that that infrastructure is happening underneath us. We actually have to report externally. We'd already started our after action review process. We hadn't realised there'd been an external requirement, but we're already on the ball to report those findings externally as well, which has also been put on us in the last week.
You're on mute, Andy.
Sorry, Jane and then David. Thanks.
Mine was just really a point for information, just that James and his team have been working on a more focused report for the Quality Committee. So just for the board to note, really, that we now receive a performance report which is very much picking up the quality and the outcomes for patients, so the Quality Committee can focus on that. So although we obviously know the overall performance, we actually do focus specifically on those aspects, and that's really welcomed because it does help us to really hone in on that. So it's just really for the board to know. Okay,
so still one performance report, but addressing both the needs of modern healthcare and the Quality Committee in one report, or
no,
two?
It's a focused performance report for quality, which picks out the pertinent points that relate to safety and quality and performance.
Okay.
Not the same report.
Okay. David.
Yeah, James, I mean, it's a brilliant report, and there's some amazing work that's there. I suppose the biggest kind of stress that we've got in the organisation at the moment is clearly flow within the organisation on the emergency pathway and the performance in A&E. And I was just looking at the length of stay stuff, because it does need a little bit more unravelling, because we've done really well in the greater than 21 days and pretty good on the greater than 7 days. But our average length of stay is approaching 7 days, and that looks historically higher than it was a few years ago. And I suppose, do you think we understand that well enough on why that is? I just wonder whether we need to look at some different data on that in terms of, you know, our community or the bed days or something to get a handle on that.
Yeah, I mean, we report it here for, I mean, it's historic reasons, I guess. I suppose outside we could work with Andrew, because the whole, Andrew's working on that length of stay piece. That'd be useful to see what the most useful interpretations are. I suppose one thing that I am aware of is the case mix that we've been measuring this is extraordinary, isn't it? It's a different, it's been predominantly COVID for 2 parts of the last 12 months. And that has had a different length of stay bias. So it's a bit different than some of our historic data. It just needs to be, I know we know that, but.
I just thought we've done so well on those longer lengths of stay, but actually the bulk of our patients are in that, you know, if the average is 7 days, then I wonder, are we just pulling people into the organisation and actually they don't need to be in the organisation, therefore they stay for 3 or 4 days, you know, before we decide they can go home. The data looks, I think we need to do a lot of work there, James, I think, because I think the work's been concentrated on the long length stay, and I think that's fantastic work. This is more the doctor's stuff, I think.
Yeah, thanks, David. That's really helpful, isn't it? And I think, you know, with the stuff that we're doing in the PAN assessment unit, the same-day emergency care that we need to concentrate on, I think they could be areas as well that we're avoiding conversion, which might help. Yeah. It could be pulling that average down.
Andrea?
Yeah, it was just to say we've been doing, from a discharge improvement perspective, quite a lot of work around the nursing staff, improving the discharge process. Also, we've got work underway with the therapists. It is the medical piece, I think, that we do need to still crack. But one element that I know, David, you've been involved with is the estimated discharge date that's calculated when a patient first arrives, obviously indicating how long that patient's going to be in. I don't think has been realistically set as best as it could do. And I know, David, there's a national bit about this as well, an improvement piece to make sure that actually when that date is set, it's set properly and we stick to it clearly. I don't know if there's anything else you want to add on that, David. I know you've been involved, haven't you? I think that'll be a winner anyway to get that correct.
Yeah, my worry is the way that EDDs are set, it's kind of a finger in the air, and people just say, oh, I think we'll get round to doing things in that time. Whereas it needs to be set in a kind of a slightly anodyne process, so we can then work out, you know, have we been slow, or have we been good at getting people home, or have there been some delays? So there is a bit of work that we're doing, Andrew, isn't there? So we've deployed Tang to look at our data to try and see if we can automatically set it, so it's not set by the clinicians who then decide how long they're going to give themselves, but there is a thing, not to understand where we're doing well and where we could be doing better. I think that's the idea of it, isn't it?
Okay, I'm gonna move us on now. James, I wonder if, though, from a graph point of view, we could have the length of stay for COVID and non-COVID separate, so that the effects of COVID could be pulled out, so that we can actually see the non-COVID.
Should we give it some thought? And we could certainly take that away as a suggestion and have a see if that would add value. It might mean that the other cohort is so diluted down by people that aren't in it where it might just get confusing.
Yeah.
We certainly have. I think if we take the action to have a look at that and see what value.
Have a think with Jane and the quality committee about that. It was just a suggestion.
I think with Andrew and David at the exec time, but should take that forward and have some thinking about
first.
Yeah.
Suzanne?
Are you on mute?
No, I was only going to say I think there's a range of data points that we need to look at. So the demographic set, the route of admission, the pre-community disposition. There's a lot of things we could look at. It could be a really comprehensive review of the information that we already have in order to understand. And I was just saying, I mean, I think the thing about these sort of evidence-based EDDs, which I've always been a firm believer in, is they can't be moved. So it's evidence-based, based on your data assessment, as David's doing, a robust assessment of what it's likely to be, and then we'll know where we fail, how many we fail, where we fail, which pathways we fail, and then that'll help us prioritise where we then seek for improvement to learn from.
Okay, good debate. Thank you. I'm going to move on now to Merrick. You've got some minutes we're going to receive.
Yeah.
Anything you want to say about them?
Well, they of course really largely reflect the minutes we've had before, which cover our continuing focus on trying to understand the operational performance in the context of meaning that historical measures and comparatives are very hard to use, not impossible. An example of that would be, for instance, we discussed at the last meeting, the utilisation of theatres, the way the numbers are presented, basically cover the theatres that we have open, not the ones that we have chosen, for all the reasons we know about, to temporarily close. And we also obviously continue to make sure that funding does not represent in any way a blocker to the operational performance of the hospital, which it has not. Covered in the summary of the bullets are two areas that we are covered and touched on briefly in the closed board, but the forward funding arrangements have just literally been issued as an outline paper. That was after the Modern Hospital meeting last week, and that also covers capital. So that's going to be an area of focus for Modern Hospital in the coming months. And there is money in there for the increased cost for Ockenden, although I don't think we're yet clear whether it fully covers those costs, but at least there is in the funding and some acknowledgement of those costs. I think that's all I have to say.
Okay, thank you, Mary. Anybody got any comments on those minutes? No. Okay, thank you. We'll move on, and we'll move on to the people agenda. And clearly, we've got the National Staff Survey results that we want to examine. I know they've been to People Committee, but before we do that, Marcin, anything you want to say about the January minutes?
Thank you, Chairman. No, I think the January minutes, are for noting. And I'm happy to take any questions. I think what I want to do is just pick up before I introduce the staff survey is the March People Committee, and two key areas really that I think our board would like to know about, which is our innovative approach to recruitment and to supporting our community in getting jobs in the NHS. You'll be aware that we were very successful in getting a lot of people to support us during COVID, the pandemic, and in particular in the vaccination hub. And what we want to do is make sure that that experience gets developed into future careers in the NHS. So Louise and her team have set up the most innovative experience called a Recruitment Hub, where they're helping people with interview practice, CV writing, actually just a conversation about what job would my skills suit the NHS. And, you know, I just think it's a fantastic initiative, really shows our anchor institution and shows our community support. And I just want to really recommend that to my colleagues. You'll hear more about it in the minutes that come out in March. So that was a key feature. We also, which links to the staff survey, had a piece on safer staffing and junior doctor hours. And I think what we've asked for is a little bit more detail and depth on what's really going on some of the wards where it looks like there's some recruitment issues. But again, positive indicators. Suzanne's already covered. Our focus now of our people meeting is on our 3 risks: recruitment, engagement, and staff sustainability. So really that's our focus. So unless there's any questions on the minutes, I'd like to introduce the staff survey.
Yeah, just before you do, just two little vignettes on recruitment, which delighted me over the past week. One was I was talking to one of the BA staff on Project Wingman yesterday, and she announced that she was joining us next week in the admin clerical side, and how delighted she was, and that working in a hospital had changed her view that there was a world outside BA, and she was absolute. And she commented on the friendliness of the trust, and that was a key thing as well, that the way people were treating each other. I know we're not perfect in this regard, no organisation is, but that delighted me. And the second one also yesterday, actually, talking to about the patient companions, that one of those is about to go for HCA and has done that. So again, that's about progression, isn't it? The very reason that we wanted to bring those in is to go on. So just 2 little vignettes from yesterday, really, but I thought they were both excellent.
So that also was a feature, Andy, of our meeting in March. We had a report. I'll come on to you, Jane, in a minute. We had a report from internal audit on our induction program, because of course inductions had to completely shift with COVID not being face-to-face. And there are things for us still to do, which is, you know, grab those people who just started and make them part of the team so that they want to stay and tell everybody else to come join us. So we had a little big, an in-depth kind of review of induction. So, sorry, Jane.
It was just to support Andy's comments, really. Thank you. Just that I've been helping out in the vaccination hub, and I've worked with 4 members of aircrew, and all of them, without exception, have said that they've been made very welcome. And 2 of them have applied for posts within Ashford and St. Peter's. 2 of them are on furlough, so they're not actually able to. But I think that was really positive, and they've been really welcomed into the team. So I think what you were saying actually seems to be bearing out. And I worked with them for full shifts, and they were nothing but positive about how friendly people had been. So I think it's really good about how we've extended our offer to the wider community.
Louise?
Yeah, I always forget we've got a secret shopper when Jane goes and does her shifts in the hub. I think it was just really to say that at the next People Committee, we're going to do a focus on the Grow Your Own part of the workforce transformation strategy. So giving board colleagues a sense of how we're trying to increase our activity around, you know, improving our work experience offer, especially in this sort of virtual world, what that looks like, how we potentially work with our ICP colleagues to identify areas of deprivation in North West Surrey, and, you know, is there an opportunity for us to do something different with those areas? So very ambitious plans. Obviously, you know, what we've described today is that sort of our first attempts at turning that into reality. But I think it would be good to have a broader conversation around our strategy around this. But yeah, thank you for acknowledging that. And obviously, things like the Recruitment Hub we've done with very limited resources. So again, you know, real credit to my team for them completely rethinking how they do their jobs, and acknowledging, you know, this massive talent that we need to convert into jobs.
Thanks, Louise. So I'm going to hand back now to you, Marcin, for the introduction to the National Staff Survey. Thanks.
Thank you, Chairman. So in our March, Louise presented the results of this year's survey. And whilst we welcome the results and we see consistency and some good improvements, obviously disappointed that we didn't have a great return in terms of 43%, a little below national average. We have asked Louise to look at some of the trusts who achieved great returns to see is there anything they do that we could learn from. So we had some really, you'll have read the report, we have really good areas of improvement. We've got consistent good performance in areas, but there are 3 areas that we spent some time on and are concerned about, which is around bullying and harassment, working over contract hours, and our whole equality, diversity, and inclusion agenda, which we've put effort into, but we know we now need to do more. We agreed at the committee that Suzanne, as chair of the EDI board, will now present at every committee meeting actions and and the conversations and the activities that she's engaged in. So we're going to spend a little more time at each people committee on that agenda item, and we really welcome Suzanne's role on this. And then I know that I think it helps us to engage with that agenda as well. What I think those 3 areas play out in is some of the information we see repeatedly in some of the conversations with our employee relations and with some of the issues going on. So I think there's issues that we need to get under, and we've asked Louise and her team to do a little bit more data collection and analysis of the contract hours and see where are the issues, where is that happening, and also we've also said that we think we need some more management capacity and training into basic good management to start dealing with the bullying and harassment issue. It coincides with the issues around appraisals and with training and just with a general culture and attitude. So we think it's giving managers a little bit more tools in their toolkit to support staff and the whole well-being agenda. And I think that culturally will flow through. So I recommend this report to you. Our committee, again, it's in line with the risks and it's in line with what we've read. And I think let's hear from Louise about her timeline and her plan, which is very well addressed at the back of the presentation about how we take this forward. So I hope that's a helpful introduction, and over to my star, Louise.
Yes, thanks, Marcin. I mean, you have a slide deck with 19 slides with a huge amount of information. So apologies if that's sort of too much to take in. But as Marcin has already described, we have taken this through the People Committee in quite a lot of detail. What my thoughts in terms of how we interpret this feedback and make sure that we're acting on it is not to start from scratch in terms of an action plan, but actually to think about how it coalesces with our current workforce transformation programme. And so whilst you've got a slide at the end of the pack that just does a nod to that, the workforce transformation programme itself has got, you know, much more detail in terms of what we're going to do, when we're going to do it, and how we're going to measure the impact. So you haven't got that today, but it was to give assurance that plan is constantly being updated based on the feedback that we get. I mean, the 3 points that Marcin has pulled out today, you know, are areas that it's not a new feedback. So it's certainly a feedback that we need to understand and need to get under the skin of in much more detail than we have thus far. And I think the piece around you know, a focus on line management, people management skills is a really important point. At the moment, that's predominantly focused on well-being conversations, and you'll understand the reason for that. But actually what we want to do is to spend much more time focusing on how we create the right environment whereby people can raise concerns, people can constructively challenge one another, people can have courteous and civil conversations that are respectful, that are about positive intent and improving the organisation in a way that then doesn't lead to the types of trends that we see within some of the feedback. And I think that is about skills development and about having a conversation as an organisation about that. Suzanne and I have talked about this a lot, and how we go about doing that in a constructive way. And I think for me there's already some activity that's in place. So in September the board received our annual workforce report on equality, diversity and inclusion, and in July we took our res report to the board, the people committee and the board, and we'll do those things again this year. But things like a review of our recruitment practices, so that we've got a mechanism to make sure that opportunities are not just given for acting up as common opportunities for that we have an open and transparent way of identifying people for those, that we make sure that our recruitment panels are trained, that they are representative of the organisation. And so a lot of work around recruitment, a lot of work around career conversations and talent, and how we encourage people to think about their long-term career and give them some support with that. We launched a mentoring programme for our BAME colleagues in July. So very much the focus around that was how we get people to get some support around career and some development in terms of how they access promotions and are successful in that endeavour. And finally, a lot of progress this year with our network. How do we make sure that we continue to engage with the network? We continue to seek feedback from them, and we don't just rely on sort of once a year staff survey intelligence, but we really do continue to have a dialogue with the organisation around where we get things right and how we can make sure we do that more often, but also where we don't get things right and how we learn from that. So just to reiterate Marcine's point around, these are priorities that we want to make sure when we're sitting here next year that we've started to see some significant improvements on. But without wanting to take away from, obviously, the really positive parts of the staff survey, and I will just draw people's attention back to those staff engagement charts, because that's a phenomenal story in terms of the culture of the organisation, and people wanting to work at Ashford and St Peters, and people wanting to advocate for the organisation, which ultimately, leads to better, safer patient care. So I would just draw people back to those charts, because that story from 2012 onwards is fairly compelling.
Thanks, Louise. Your sound isn't great for some reason today, Louise, and got a bit of feedback on your sound. Aaron.
Thanks, Andy. Thanks, Louise. That was really informative. Just a very quick question, and it was just about the BAME mentoring that you mentioned. Is that with externals, internals? Is that under allyship, or is that with peer mentoring? Just out of interest, really.
Sorry, I'm messing with my headset and I didn't hear that, Aaron. Could you repeat it?
Yeah, sure. I was just asking, the BAME mentoring, is that with, out of interest, just for my own interest, is that with externals or internals, and is that under the concept of allyship, or is it peer-to-peer mentoring?
Gosh, that's a lot of detail that I probably haven't got. I think it's a programme that we're supporting internally, but I always welcome some advice or some examples of best practice from elsewhere if you think you can share those with us.
Okay, I'll do that offline.
Suzanne.
Thanks, Louise, Marcine and Andy. I mean, it's a really mixed and rather confusing picture, isn't it? I mean, it's really disappointing to see those feedbacks around the bullying, harassment and the persistence of that, because as Louise says, that's not a new feedback for us despite our approach. And one might anticipate that if you're getting those sort of steep and then sustained improvements in the advocacy and scores and the motivation scores, so there's something that doesn't quite add up. And I think so the work that Louise is committed to do with us and others to keep understanding. And I think a lot of this is about just speaking to colleagues in a really authentic way and seeking to understand, so that we can work with the team to address those issues, build capability. David might want to comment, but we were fortunate enough to listen to Matthew Saeed speak at the Army annual conference, and he spoke about cognitive diversity in a really positive way. And then that really sort of engaged me in my thinking around all of this. That was interesting. And Sal and I are going to try and invite him to do sort of a leadership masterclass if we can secure someone of such great national eminence, to help us with our sort of, keep sort of challenging us in our thinking. And the other thing I think is really important, and I'm really keen to lose, and is a big focus for us at the EDI committee, is the kind of inequalities in health, access and outcomes, and how that links directly to some of this, the sort of experience of our colleagues, and how that influences and shapes how our patients and our community experience accessing their care, and how it shapes our thinking about how we provide care and how we go about that and working with communities to get that right. And so there's a huge amount of work to be done on that agenda, and some of you might know that as part of the new contract for this year, there's a requirement on, I think it's me specifically as the chief exec, to kind of I've got a duty to work with others to address issues of health inequalities in terms of access and outcomes. So that's a helpful elbow leverage, isn't it, there, in terms of getting some focus on that. So I'm thoughtful about this, and I think we've got to keep talking and reflecting and mostly engaging with our teams to understand what it is that we can do to work with them to address the issues that some of our colleagues are sadly continuing to experience. Thanks.
Thank you, Suzanne. Any other questions for Louise around the staff survey? So I think in summary, there's some really good things in here. We always, want to improve, and we go to the bottom 5 and we go to the things that are least improved and we focus on those, and that's right, absolutely right to do so. We need to keep improving, but there's some really good stories in here as well. Some really good about staff engagement, that constant improvement. And I was really struck by the number of our colleagues who want to recommend this as a place to work, and that's, I think, 70-something%, which is a really, really good result. So yes, we've still got plenty of work to do, particularly on the bullying and harassment and on the EDI agenda, lots and lots of work to do, but actually we ought to say that we are continuing to do some things very well. And I think the whole wellbeing programme, which Louise and her team have been sponsoring across the organisation during the pandemic, is such a great example of this, and the Recruitment Hub that we've heard of. So I just want to say, yes, we've got lots of work to do, but thank you for all the work that's been done so far to all the executive team and everybody else throughout the organisation. Okay, so we move on now. And we're going to move on to Chris. You've got the digital committee minutes. Anything you want to say about those?
Sorry, just come off mute. So this again was back in October. So we have a quarterly review in the digital committee, and so things have moved on. Suzanne's updated you in terms of safe care, which is great. I guess this really the things to highlight. I'll take it as read, but is we renewed the terms of reference. They were updated and the approach was approved. I guess, the continuing focus on the improvement of the BAF and the presentation of risk and how we do that. And I think for digital, it was really about a coordination exercise between what we're working with the Royal Surrey, focusing on what we do as a trust, but also making sure that aligns with what's coming out of the Surrey Heartland ICS. So the digital committee in the open forum really focused on that. And a lot of the really good tactical things we are doing in the trust to improve technology and enabling good service. So I'll take it as read and any questions that you might have.
Thank you, Chris. Any questions for Chris on the digital side? No, thank you, Chris.
And the extraordinary one, although that didn't need to come to board because it was signed off, the business case was signed off around improving a new data centre to improve our data resilience. The business case was signed off by the Modern Healthcare Committee, but it's really just a point to note that went ahead, and we explore various issues, physical issues, with water supplies in terms of how that's going to be delivered. I don't know whether Simon wanted to mention anything in terms of the update on that.
Just confused, Chris. I mean, the server farm works have been delivered, and in fact have been delivered in the last couple of days. So have I got the wrong end of the stick?
I don't know.
Between as well. I think that's what you're talking about. And yes, it's been delivered.
This is what I mean, this goes right back, doesn't it, to November, when we had the extraordinary meeting in terms of the new data centre.
Yeah, so we've obviously taken action since to resolve that issue.
Yes.
It'll go online. There's still some, what do you call it, kind of software being installed, and obviously data migrated across to it over the next 2 or 3 months. But basically that risk has been addressed. We also received some extra funding from the centre in late February just to help that. So the process of being sorted.
I think the important thing is that does address one of the BAF risks.
Yeah, absolutely.
So that's important, going all the way back to where we started with the review of risks in Suzanne's report.
And also, when we're going back almost 6 months, it's things go out of date very quickly, don't they? Especially in digital world.
Okay, thanks, Chris, for that. So we're now going to move on to the regulatory section, and we've got the Audit and Risks Committee minutes. And we've also got terms of reference here, haven't we?
That's correct, yes.
Can you just on the terms of reference, because certainly on my copy there was no highlighting to say what had changed?
That's because nothing has changed.
In which case that's quite an easy discussion, isn't it?
Hopefully, yes. So just actually picking up on Chris's comment a moment ago about the time lag between some of these committee minutes coming to board, and the fact that a lot of work will have flowed subsequently. You'll have got here 2 sets of minutes from our January and March Audit and Risk Committee meetings, and that's because I'm working towards endeavouring to have a fortnight gap between the committee meeting and then a full board, so that actually we can have much more up-to-date minutes coming to board and not have this big gap. And other committees may or may not be able to achieve that, but I would suggest that's helpful in terms of our overall board governance. So the first set of minutes for back in January, I just want to pick out one item, which is in 4.2, which was to do with internal audit recommendations. So this is on, looking at the document I've got in front of me, it's on the 4th page of the 27-page document you've got. And really what I want to just highlight here is that this summarises the progress on the audit internal auditors' recommendations being followed up and implemented. And here you can see, looking back over the last 3 years of their work, how relatively few recommendations are still outstanding. When I look back about 4 years, I seem to remember at one stage we had 53 internal auditor recommendations that were outstanding and that hadn't been worked through. And now to be down to a dozen or less, I think is just remarkable work that's being done by the team, and that affects many different areas of the trust work, because the internal audit obviously looks over everything that we're doing. And so I just really want to draw out and to commend the work by the leadership team in terms of taking action on recommendations and getting them implemented. So we've made huge progress, and this has really added value to us as a trust through the internal audit work. The second set of minutes, which were from our meeting just a couple of weeks ago, I've got nothing particular that I wanted to highlight, and I'll also speak immediately now to the fact that we don't need to bring any changes forward in terms of our terms of reference. We did quite a lot of work on our terms of reference a year ago. You may remember we particularly wanted to update the sections to do with our risk oversight, and slipped my mind, sorry. There was another aspect of our update, but having done that, we now feel that the terms of reference are fit for purpose and describe our work accurately, so we've got no further changes to propose.
Okay, thank you.
So over to colleagues for any questions or comments on these minutes and terms of reference.
I think Jane.
Thank you, Keith. It's just really for the board to be aware that you will notice that one of the internal reports, which was around discharge to assess,
yep.
And this has a limited assurance. There's an echo on the line. I'm sorry, I don't think it's me. As limited assurance, and Marcin, as a member of that committee, did flag that to me to ensure that we looked at that in a little bit more detail at the quality committee. So at the quality committee last week, we had the deputy chief nurse who attended to provide assurance around the actions that were being taken, and we were pleased to see those actions, and we're assured by the improvement actions that were going ahead. So it's just to say that that link across is really important. Thank you to Marcin for raising that, and thank you to the team for bringing that quickly to the quality committee so that we could understand what improvement actions are going ahead. Marcin, I don't know whether you want to say any more on that one.
No. I would like to say, and I'm going to kill me, Keith, upon reflection, I am wondering, the triangulation from Audit and Risk Committee to the sub-board committees is a very valuable tool in helping the executive and the board have assurance around the internal audit function, something I want to work with Suzanne on. And I am wondering if we want to put that in the terms of reference to have that sort of triangulation, and it might just help us. So maybe it's some thinking, Suzanne and Keith, we do offline and bring it back to one of the committees as we start to, I suppose, become a little bit more educated in how we receive, commission, and deliver internal audit reports. Just a thought. And I'm sorry I didn't bring it back. I didn't bring it at that. It's just, it's now starting, I think, to be more effective. And what we need to do is think how that works in terms of governance on our terms of reference.
No, I welcome that. I think we can take these forward as they are, and then that can be fed into a further review as we implement those sorts of improvements. But appreciate that suggestion very much.
Yeah, I think that's a very good suggestion. Any other questions for Keith on these minutes? I've just got one, is to say, and it's with relation to the latest minutes, the stock check. Have we got any update on the stock check? Given
Simon may be able to speak to that. I don't know. We were something that we concentrated on.
Yeah, we had an update at the audit committee, and that's progressing in line with the agreements we put in place with Mazars. So we're expecting that to go through straightforwardly, I think, this year. I'm touching wood at the moment, hoping that's the case, but nevertheless, that's our expectation.
Okay.
There was a question, Simon, as to whether the amount of equipment nationally, so test and trace or whatever it is, that was going to actually be allocated to us would trip us over from performance materiality to something more substantial in terms of external work. Have you got a sight on that now?
It shouldn't do. We've just got a final few minor areas to come in, with the year end only being yesterday.
Yeah.
So yeah, it's going through those counting processes. We've had all the central amounts confirmed. I think there's about 400,000 of that stock that's left. So again, it's not. It should be okay.
Yeah, good. So yeah, we have given that some thought. Thank you, Andy.
Yes, no, I saw that in the minutes, so I just thought it would be worth getting the most up to date.
Yeah.
Because we didn't want to be in the position we were in last year.
No. Thank you.
Right. Okay. Thank you for that. Trust seal, Simon. I think you've used it once.
Yeah, relatively straightforward. We've received another 6.5 million of the deferred land sale receipts. So we've released the appropriate bit of the land charge that was on that land. There's one more to go, which will be in a year's time. And yeah, so a final 6.5 million, but completely in line with the original deal at the moment.
Okay, so that's good. Okay, which moves us on to any other business. Has anybody got? I've not been cited on any other business. Anybody got any other business you want to bring to us? No. Okay, so we've got questions from Liz. I believe we've got a couple of questions from the public that were submitted through the website.
Yes, we've got one question.
One, could you read that out, and then I think David is going to deal with it.
Yeah, we'll do. Does the trust have a policy covering use of DNA, CPR decisions and the respect form? And what information is routinely given to patients about the existence of these forms?
Okay, that's a good question. I think it's from Rosemary, wasn't it?
It is, yeah.
So thank you, Rosemary, for that question. David.
So the respect form is well established in our trust. We've had a policy embedded in the trust since 2018, and it's due for review in August 2021. I think the important thing to say, this is an important part of shared decision making for all patients undergoing treatment within a medical setting. I think Rosemary was also asking about how we signpost next of kin and relatives to that, and there are leaflets available, and there's also signposting on our website. What the respect form, it's really important to understand what the respect form is, and the respect form is a record of the discussion between medical staff involved in the care and the patient, if they have capacity, but there are we have provision if patients don't have capacity to talk to people who are either the advocate or their relatives about this. And a decision is therefore jointly discussed and reached. Now, the programme was introduced in our hospital under the guidance of the palliative care team and the critical care team, with a lot of support from the medical division. It is clear it is not a DNAR form at all, but it is important to say that when discussions are held with patients, it's not a unilateral medical decision, it's a shared decision, but there are some times when the condition of the patient means that resuscitation or intervention by some mechanism will be futile for the patient, and we have to have an open and honest conversation with patients and their relatives and advocates about what the best way forward is. And the respect form is a way of having that discussion early on in the process when patients are admitted, and making sure that everyone's informed on what the best way forward is, and that we're all agreed that's the best way forward.
Okay, thank you, David. And how does whether patients or relatives of patients with lasting power of attorney on medical matters, how does that affect things, or doesn't it?
Well, it does affect things, but you have to remember that power of attorney, there are different powers of attorney. Okay, So you can have financial power of attorney, or you can have health power of attorney.
That's
so
why I said health. Yeah.
Yeah. So you need to make sure that they do have health power of attorney, and you need to make sure that they're not just saying that you do know they are the person, and also if you also assess that the patient has capacity. It's really important that you have a conversation with patients and have capacity. And as I'm pointing out, this isn't that in situations there are some medical interventions which will certainly not help and may cause even more harm, and therefore it is important that discussion is informative. But this isn't a patient says I want this treatment. It's not a discussion around that. It's around about informing and letting people understand what the right way forward is. I think the DNAR policy was, where that was is where these discussions weren't held properly. And it's all about the way you do it. It's not about the form. It's about the culture and the way you engage and talk to people. And that's what I think has come in the press, which has caused so much concern amongst patients and relatives and medical staff as well. So it's about making sure the right conversations happen at an early stage with the right people.
Thank you, and it was useful to have that question because of because of the press interest recently in that, and obviously some places maybe haven't got it completely right in the past. Okay, was that the only question, Liz?
Yes, that was the only question.
Okay, thank you. So we are at 12:53. We're due to finish at 1 p.m. Any reflections on today's meeting on anything that we've covered? No? Neil?
Well, just one, because actually it does assure me hugely to have fellow non-executives describing the committee meetings that they chair through the lens of risk, because we don't all sit on everything. But it does seem to me that we've got a pretty consistent professional stance now, which I welcome, and obviously the executive team are part of that as well. So it makes the overall risk picture facing the trust much more visible. I think we did have, both Marcin and I, a comment that says, with Suzanne's report, I think we just need to make sure that the alignment between the commentary and the current risk status is a bit tighter. But I think we've got the basis and the information coming forward to do that, and therefore that was an incredibly constructive, helpful meeting. And I find that risk framework stops us getting into all the weeds as well, because it means that we look at an issue rather than question more randomly. So I think all very helpful and a big development on some years ago. So thank you.
Yes, I think building on that, Neil, from my perspective as chairman, I think the subcommittees are working very much better now than they were, I don't know, 3 years ago or something. And just in a more structured way around risk. And I think it is really, really helpful. And I do attend most of the subcommittees whenever I can. And I'm really gratified that the discussions around risk are becoming more fruitful. And we're on a journey. We're not there yet, but we are on a journey. And I think the work that Marcin and Sal and the team have done as well in the background has really helped.
So now our task is to really help the ICP and the ICS to get them in a place where their decisions are risk-based and have evidence. And so I have put up Suzanne's paper as best practice and something for both groups to think about and how they implement that. And they're still debating whether they believe in risk appetite. So we're a long way ahead, and we'll keep working with them. We have the next meeting next week.
Yes, thank you. I've deliberately put you forward as the grit in the oyster there, which hopefully will come out to be a pearl in the end. So thank you for that. Okay, so thank you everybody for your participation. Those members of the public, especially members of Ashford St Peters and indeed former members of Ashford St Peters who've sat in on the open board meeting today, hello, and I hope you've found that useful. I know there's a lot of master's work going on there, so we loved having you on board.
Fantastic.
Hope you found that useful. And thank you to the members of public and governors who've joined us as well. And the next meeting is, Liz, when's our next meeting? Just so we're clear.
28th, I think, of May. Hold on.
Last Thursday in May, I think.
Yeah, I know. Hang on, let me just look on here. Sorry. Yeah, the 27th of May. Yeah.
Okay, so we will meet again as a board, if not before, on an extraordinary 27th of May, and no doubt see you all long before then. Thank you. Bye.
Bye.
Bye, everyone.
Thank you, everybody.
Yeah,
really good meeting. Thank you.
Thank you all. Very happy Easter to all.
Thank you.
Oh.